My name's Victoria Bett, and I'm chairing this next session on the workforce crisis, a really important and very topical issue. Just briefly, a little bit about me. I've spent the last 7 or 8 years working in the digital health sector, mostly from within the NHS, but more recently from within industry. And I'm also doing quite a bit of work with the Northern Care Alliance with Salford Community Services, helping them with their digital strategy. So really delighted to be in the city, and also very pleased to be here with the Tech UK gang. I'm the Vice Chair of the Health and Care Council, so very nice to be along with those guys too. What I'm going to ask each of my lovely esteemed panel members to do is to briefly introduce themselves. David, you've obviously done that, but I would like each of you to just say for a few seconds why you care about this topic, health tech and the workforce crisis. So just tell us who you are, what your product is, and why you care about this topic.
So Melissa Morris, nice to meet everyone. I'm the CEO and founder of a company named Lantum. Lantum is a workforce management platform for healthcare, so naturally I care quite a lot about this topic. It's a scheduling tool that helps organisations to schedule staff, but also to share staff. And we also build hyper-local networks of clinicians around organisations who can work flexibly and fill in gaps. So it's all about kind of workforce efficiency within the NHS. My background, I previously worked within the NHS London. Before that, worked at McKinsey as a management consultant, and I have been focusing on workforce within the NHS for like about 15 years. So yeah, something that I hold very dear to my heart.
Great, thank you so much. And Taz?
Afternoon everyone, Taz Aldwood. I'm founder and CEO of DocAbode. Also a workforce management platform from the very beginning, from onboarding, rostering, HR, and then actually deploying the workforce. And we work at a patient level, really matching patient needs to the right clinician at the right time. Workforce, it's the common denominator for everything really in the NHS. Whether it's a strategic operational objective, it's all about the workforce. I've been a practicing GP for about, over 10 years. My background, I've worked NHS England for 5 years around digital transformation. I'm also, and still am, been on the commissioning board across the Pennines over in Bradford as a board member of Bradford District CCG. And they also created a more digital role. I'm their Chief Clinical Information Officer as well. So really having a sort of digital IG tech background and passionate about technology, and that's why I set up DocAbode.
Thank you, Taz. And David, we know who you are, but tell us a bit more about why you care about this topic.
So I see it on the day-to-day in the ground. There's, it's not just doctors and surgeons that are trying to pivot away from just pure clinical work, but also I see nurses, I see healthcare workers, the wider MDT, even porters have been stretched, and especially after what we've been through over the last couple of years, where there've been mass deployment, there have been no annual leave, there's been no holidays taken, people have just worked flat out, and then they've come back into a world where they're expected to, especially GPs, deliver so much more than they were previously under extreme conditions. There's so many extra COVID paperwork that you're having to do, which on top of, as we've spoken about in the previous panel, being vilified and brought up in the press on a regular basis. It's really tough, and I see a lot of my colleagues going through, burnout, going through, looking at the grass is greener when it actually most of the time probably isn't. And workforce retention is something that's really close to my heart, because it is tragedy to see this. Plus, the NHS, as you imagine, is an unlimited demand but very limited supply situation. So I really hope we can come up with some solutions today.
Thank you, and thank you for painting a picture of what it's like working in the NHS clinically, over this really dreadful period. Okay, so a few fun facts for you. You might know some of this. So the NHS is the largest employer in England with 1.2 million hospital and community staff. So, staff are the biggest asset of the NHS. But there's a shortage of 840,000 full-time equivalent staff, and 1 in 10 nursing posts are vacant. So we've got a big problem. I did what any good chair should do. I Googled workforce crisis in the NHS while I was sitting here waiting to come on. And first up was the King's Fund and their analysis of the workforce crisis. And they say that The prolonged funding squeeze combined with years of poor workforce planning, weak policy and fragmented responsibilities have resulted in a workforce crisis. So this feels to me like a pretty systemic issue. Interestingly, Kingspan don't mention technology once in respect of the workforce crisis. So my question to you as a panel, is technology an important part of the answer, or is it obfuscating? Taz,
happy to go first.
You go first.
Yeah. I mean, I'm disappointed about the King's Fund not mentioning technology.
Well, they've got a whole thing on tech, but they haven't integrated it, have they?
No, absolutely. I think the challenge is there isn't, it's a fragmented system, the NHS. I think it's now really clear that one organisation, take general practice, can't do everything on their own. So I think it is around how do we utilise a fluid workforce? So we talked about ICSs and practices, primary care networks and that place. So bringing community, trust, primary care together, social care, voluntary sector, it's how do you bring that place together as a workforce? And I think it's really difficult to do in the best of times. I think the right technology is just able to lower those boundaries, basically. If you're able to, whether it's HR, passporting, how do you get the right person out there without blocks in place? So I think that's the importance of technology, making our lives easier to be able to actually see people. It's the person, the patient is in the center of all this. And we're just trying to do our best, like the demand supply, there's always going to be more needed from us. I think technology, whether it's through, I know people have talked about COVID, I believe, we have done things massively in the last 2 years, but they should have been done about 10 years ago. Yeah. So being able to, do telephone consultations, video, all that should have happened. And yet we're now doing it more at scale. But there are risks of kind of widening health inequalities with digital, and we just got to be aware of some of those things as well.
I will come back to health inequality. So what you've talked about, Taz, is actually the mainstreaming of some very well established basic technologies such as video consultations, and we've seen those adopted at scale and Teams and so on. David, you're right at the innovation, it seems to me, end of this. And I might be wrong, someone correct me if I'm wrong, but I think it takes about 15 to 20 years, they say, to get an innovation adopted in the NHS. Where are you in that curve? And, it just feels to me like we're talking at a very basic end around scheduling and so on, and then this at the innovation end about this really complicated thing. Talk to us about that sort of innovation sort of adoption curve.
So we're actually doing quite well in terms of, especially in O&G, we're almost supplying most of the deaneries around the country that are involved with issuing these boxes to trainers, and this is really quite amazing that we've come that far. And we're also starting to look at expanding into outside the UK as well, but reinforcing that in the UK across all the specialties that we do supply is one of our keys. And certainly it's been a challenge. Obviously, from the stories I've heard from the team, there's been a lot of resistance to change. And I think one of our biggest moments was during COVID. And as you talked about, COVID accelerated almost 10 or 20 years of change in the space of a couple of months. And as I've touched on very briefly in my presentation, the ability to do things remotely and continue learning remotely was one of our key core values and one of our key winners there. And really, it's not just about the innovation and the tech and whether it be digital health or real tangible tech. It's also really about kind of changing everyone's thinking. We were really fast-tracked and almost catapulted into thinking, well, the NHS is not just about service anymore. Our grandparents went through an industrial kind of age or revolution, and our parents went through a service, revolution. But we're now going, and we've realized, especially during COVID, that we have an identity revolution going on right now. And when we talk about retention of the workforce or solving the workforce crisis, we've got to remember that these nurses or these vacancies for these nurses or whatever position or post is not just about the nurse and not just about that particular job role that needs to be filled or the nursing role. It needs to be about the person that's coming into that role. What do they have going on in their life around them? What are their training needs? What do they aspire to be in 5 or 10 years' time? They're not coming in just to fill a post and do their job anymore. It's not just a service. It's about their identity. And that's really what I want to talk about, especially not just in our training, because this is very customizable and the software is all about you as an identity on the cloud. But it's also about how we can apply that to digital tech and digital health in order to make sure that we're thinking about our employee as a human.
I'm going to thank you for that, David.
Yeah,
I'm going to open out to questions in a minute, but I just want to ask Melissa a question. So Taz, you touched on health inequalities, but we've also got some challenges around workforce skills and capabilities and competence when it comes to use of technology. Is that something that you see in the work that you do, and how are you thinking about that issue around usability and accessibility for staff?
Yeah, well, I think, well, just going back to what you were previously saying about the King's Fund not including tech in workforce, I just think is actually shocking, because there is no way you can solve this workforce crisis without technology. Like, just to give an example, the average recruitment agency will fill 20% of shifts that they get sent. And on Lantern, basically, we match latent capacity. We know when people are available. We match that capacity with shifts that are available, and we fill on average 90%. And that's because we are technology first. So I just think that excluding it is crazy. In terms of usability, I think there's just been such a big shift. So I think, back in the day, some of the tech that is in the NHS estate, that has been there for years and years and years, is really hard to use. People tend to do all these kind of manual workarounds and pen and paper, Excel spreadsheets to supplement them because they're so hard to use. And that has given people a bit of fear and thinking that, that onboarding must be really hard. But actually, modern technology is much easier to use. There's been a big consumerization across, including in B2B technology, that makes it much, much easier. And there's all sorts of plugins and things like that our developers, for example, can bring on to make it easier to improve the onboarding journey, so you don't have to build it all yourself. So I just think that the modern technology is very, very, very different to the kind of old software that you see that is still sort of in situ. So yeah, and I think also modern software is much more conscious of accessibility standards, because actually people are quite obsessive over usability metrics and tracking, and particularly if you're, if you want to grow from within your product. So I don't think it's as much of an issue as it once was.
So it is that usability, really simple onboarding, and a really intuitive, easy experience. But I think my experience, and I'm sure others, has been that clunky technology sort of puts clinicians off, and that's their sort of ground experience. But actually, there are more sort of intuitive products coming online that people can use.
Yeah.
Okay, thank you. Who would like to ask a question? So we've got one over here. Thank you. And would you like to say where you're from?
Yeah, hi, I'm Kira. I'm a GP. I'm currently doing my MBA in Manchester Business School. This is a question for David, actually. We recently had a talk from the global head of health from KPMG about the global issue with the workforce crisis. And he said that the factors that underpin it are to do with poor leadership. And I can't remember the second one he said, but he was talking around the role of technology and kind of reinvesting in the training of particularly clinicians, because currently the spending in the UK is 80% of the spending is actually in medical school, and only 20% kind of postgraduate, and that basically clinicians are becoming disenfranchised, and then that's massively feeding into workforce planning, because just because you graduate as a medic doesn't mean you'll be a medic in 10 years. So how, obviously this is your baby, but if you were to kind of innovate a future product to kind of address this problem, do you have any thoughts about what that might be?
Yeah, I think just from experience, it's interesting you say that. You're right, medical schools are very subsidized, but we don't think about pre-med. So, the Royal College of Surgeons and some of the colleges only have just started to approach us about widening participation from school, when this is, should have been something that would been implemented 20 years ago. Well, it was in my med school. But certainly moving forward to that postgraduate teaching and training is actually on the onus of the surgeon or the doctor. They're having to fork out, as you know, so much money, so much of their own cash, already on a tight budget, potentially if they're having a family and a mortgage and they're having to, juggle all the, £1,000 per exam or 500 quid for a college membership or a GMC membership. It does add up, and the difficulty there, it becomes almost a cost barrier. Now, you do have obviously a lot of people that go into medicine that have that come from backgrounds where they're able to afford these things, but this is exactly the point. There are lots that don't, and so what happens is that when trainees slip out of the training world because they can't afford it or because they can't keep up with it, they then end up going into the locoming world, where they try and make a lot of money, which actually compounds the workforce crisis even further, because we're spending more money as a King's Fund on locums, which I think, and I wrote a post about this the other day because I'm so passionate about it. We are wasting a lot of money on that. And why can't we just at the beginning, sadly that new workforce planning was rejected by the MPs the other day, but there was scope by Jeremy Hunt to increase the amount of number of trainees available for us to be able to at least take training forward and fill in those numbers later on. So I think one thing, if I was to innovate a product that would change or help this, would be to at least find out where our imbalances or gaps are across the country in terms of what specialists, what fields in medicine and surgery, and then create a method for almost like a direct feedback for NHS England, now that they're taking over Health Education England, for them to realise, actually, we need a training spot there and we need it yesterday. So not something that will take 2 or 3 years to implement, but actually something that will happen now, because that one more trainee there will mean you'll probably have a consultant working there in the future, on top of the fact that you're then saving all that money on a locum. And you're training someone in the process who, hopefully would have better funding as well. So it's really a multi-pronged issue, and I could rant about this all day. But thank you for asking that question. I wonder what you guys think of it.
I was going to say that there are demand and capacity tools in primary care. So trying to pick up on who you might need to be able to get your right rota and things like that. The problem is, it's just so reactive. So the tools are there, and then that's where platforms like ourselves and Lantern come in. Knowing the availability, trying to match what you think you're going to need. So there's a sort of static okay, well, let's fill a rota to here, but then actually that last sort of 10 to 20%, you're then having to use locums. We use a lot of locums in primary care as well. But actually, it's about knowing what you need, how you match your demand and capacity, because COVID, what COVID has done is made the unpredictability a lot worse. So now we're going to a situation where, whether it's self-isolation, sickness, for whatever reason, the demand is really hard to gauge. So you then end up having either, in some cases, too many workforce on, so you're actually probably could be spending the money elsewhere, or at a time where you haven't got enough, and then you're creating clinical risk, delays. You've seen all the things on the news around ED, emergency departments, 999. The symptoms, sometimes we get blamed as GPs, you're not offering enough access. And someone did say earlier, not being able to see a GP. General practice has been open, and we've taken an absolute battering from the press. But we, from the centre, were told, go total triage. And I do believe triaging is the right thing to do, because you can't just have a system where you ring up 8 in the morning and it's just potluck whether you get through. And unfortunately, a lot of general practice is set up in that way. So you can't plan the workforce if you're just reacting in this way the whole time.
Right, we've got time for one more question, I'm afraid, because we're almost out of time. But if we just take the question, person at the back. Yeah, you go ahead.
A tendency in human nature, and certainly in the NHS, is to think that doing more of the same thing will solve a problem, as opposed to doing something different. So we have, I think, Melissa mentioned 800,000 vacancies in the healthcare professionals. Certainly to train doctors and nurses takes many years. And it'll take 5 to 10 years going that route to solve the workforce problem. But there are technology solutions. And we tried telephone consultations with GPs as the public pushed back on. Because when I do that, call the GP and they say, well, what's wrong? Take 2 paracetamol or come see me. It really doesn't solve the problem. But there's different kinds of interventions, like teleconferencing. And a number of years ago, I was chairman of Airedale NHS Foundation Trust, which is the pioneer in telehealth, telemedicine. And we set up rooms with monitors and trained nurses and doctors remotely monitoring visually the health outcomes in healthcare homes and in prisons, saving enormous costs and personnel. And that hasn't caught on. So why aren't we using more of those more sophisticated remote diagnosis and treatment just to address the healthcare crisis?
So I know Airedale, obviously it's in my patch very well. I've been into your remote monitoring. I think and it has actually scaled up. They were one of the vanguards. I think their video is 1.5% of consultations in general practice. In acutes and specialties, it's a lot more. I think there is understanding when it has value. But to your earlier point, this isn't about GPs. We are few and far between. there are a huge number of, in primary care, they call them additional roles. So actually the centre have paid for up to 20 different types of, whether they're physios, pharmacists, physicians associates. There is a huge workforce coming in, but it's how do you utilise that workforce in the most efficient, best possible way? So that's the real opportunity. And I think technology can support in some of that, as well as using the sort of virtual models as well.
I think taking the telemedicine example, it feels like there hasn't been the right sort of business model fit. So like it started out by, I think Babylon first started out by asking patients to pay, which they didn't want to do because why would they when the NHS is free? Then Babylon evolved, took over a GP practice, and then threatened all the GP practices by thinking, oh, you're just going to steal all of our patients, and particularly the patients that are the most profitable. So that didn't really work, and people kind of really pushed back on that. Then there's been other models where there's been kind of SaaS models where people can sell their software as a service, telehealth solution, but GP practices, from the ones that I speak to, think that's too expensive. And so I think it's just about finding the fit, because actually GP practices, they're all independent contractors. They can choose to do what they want to do. And I've just noticed that pushback has really been around that. I think when you look at adoption generally in the NHS, for technology, people just don't want to take a risk. Nobody ever got fired for doing the same thing. And actually quite a few people do get fired for taking a risk and it not working out. And I just think that's just the nature of healthcare. So I think there's a sort of general, thing, which is the people problem that was mentioned on the previous panel as well.
I think someone once said to me that innovating in the NHS is trying to fix the engine while it's still running, and it sort of feels like that from having tried to do it both inside and outside. Thank you for that final question, and can we give a big round of applause to our fabulous panel?